Hello everyone, welcome to my channel Surgery Nuggets. This is me, Dr. Himashri. Today's topic is hiatus hernia. Hiatus hernia is a condition in which the abdominal contents migrate through the hiatal opening of the diaphragm into the mediastinum. There are four types of hiatus hernia. The first one is sliding hernia, which is most common, seen in 85 to 95% of cases. Here, the esophagogastric junction is herniated upwards. Type 2 is also known as rolling hernia. This is a true paraesophageal hernia where there is asymmetrical herniation of stomach next to the esophagus. The esophagogastric junction remains in its normal intra-abdominal position. Type 3 is mixed hernia, which is a combination of type 1 and type 2. In type 4 hiatus hernia, the abdominal viscera other than the stomach migrate into the hernial sac. This is the picture of four different types of hiatus hernia. This is type 1 hiatus hernia. You can see the esophagogastric junction has migrated upwards. This one is type 2 hiatus hernia. So this is type 2 hiatus hernia. Here you can see the esophagogastric junction is in its normal position where the stomach is migrated upwards. The third picture is type 3 hiatus hernia. Here you can see the esophagogastric junction has migrated upwards. At the same time, stomach has also herniated. Last one is type 4 hiatus hernia. Here the abdominal viscera has migrated upwards other than the stomach. Coming to the pathophysiology of hiatus hernia. Hiatus hernia is closely related to advanced age and obesity. The two key events which facilitate formation of a hiatus hernia are: the first one is widening of diaphragmatic crura at the esophageal hiatus. Second, stretching of phrenoesophageal membrane. As the hernia enlarges, the phrenoesophageal membrane balloons into the posterior mediastinum like a parachute. After repeated episodes, there is adhesion between the hernia sac and the thoracic structures, which prevent the hernia contents to return to the peritoneal cavity. Now, how to diagnose a hiatus hernia? First of all, clinical presentation. The clinical presentations for hiatus hernia are diverse and non-specific. A sliding hernia predisposes to gastroesophageal reflux disease and usually diagnosed in presence of reflux symptoms. For asymptomatic patients, it's an incidental finding on plain chest X-ray or CT thorax. The paraesophageal hernia, which may cause obstructive symptoms, are dysphagia, odynophagia, postprandial chest pain, or early satiety. Spontaneous reduction may sometimes provide relief of the symptoms. The gastrointestinal bleeding can result from mucosal ischemia or mechanical ulceration of the gastric mucosa. Coming to the investigation part, barium study helps to see the gastroesophageal anatomy and helps to diagnose a hiatus hernia. Endoscopy evaluates the gastric and esophageal mucosa for mechanical gastric mucosal erosions, that is Cameron ulcers, that can result in gastrointestinal bleed. Manometry is the most important investigation for hiatus hernia. Another important investigation is ambulatory pH monitoring. Here you can see these are the two domes of the diaphragm, and here this is the stomach which has herniated upwards, and here you can see the gas and fluid level. of the stomach. So this is a case of hiatus hernia. Coming to the treatment part, there are basically two conditions. One, when the patient presents with acute conditions like obstruction or GI bleed. In those conditions, we have to first resuscitate the patient. We give a Riley's tube and nasogastric tube decompression is done. Immediate surgery is needed if there is suspicion of ischemia, perforation, or unresolved obstruction. And this surgery can be done through left-sided chest or abdominal incision with open or minimally invasive techniques. Mostly laparoscopic repair are preferred. So there are 4 steps of surgery. The first one is reduction of the hernia contents to the abdominal cavity. Second is complete excision of the hernial sac from the posterior mediastinum. Then we mobilize the distal esophagus to achieve a minimum of 3 cm intra-abdominal esophageal length so that there is tension-free repair. And final step is to do an anti-reflux operation. So this is a picture showing Nissen fundoplication. So this is Nissen's fundoplication. Here we have seen this is esophagus and this is the crust of the diaphragm. This is the esophagus and fundus. First, we reduce the hernia contents to the abdominal cavity using gentle traction. If adhesions prevent visualization of the left crust of the diaphragm, we divide the short gastric vessel to mobilize the fundus. And safely expose the left crust of the diaphragm. To facilitate complete excision of the hernia sac, we enter the posterior mediastinum outside the sac. This plane lies between phrenoesophageal membrane and left crust of the diaphragm, and care should be taken not to injure vagus nerve. The peritoneal sac should be divided entirely parallel to the left crust of diaphragm. So after the hernia contents are returned to the peritoneal cavity, the hernia sac must be transected circumferentially at the hiatus. And once the sac is excised from the mediastinum, the esophagus is further mobilized. So we have to mobilize the esophagus to obtain a minimum of 3 cm of intra-abdominal length. Crura are re-approximated with interrupted non-absorbable suture, and tension-free closure is done, which is a key step in the repair of primary esophageal paraesophageal hernia. Now this is the Nissen's fundoplication, where we wrap the fundus around the esophagus. Posteriorly, we wrap the fundus around the esophagus, also known as Nissen's 360-degree fundoplication. This is another diagram showing door and two-pit fundoplication. Door is the anterior fundoplication. Here, the fundus is sutured anteriorly. And this is two-pit, where fundus is wrapped around the esophagus posteriorly, also known as the two-pit posterior fundoplication. Thank you for watching. If you want more videos, please like, share and subscribe to my channel. Thank you. Enjoy learning.